All right, we're going to start in just a second. I see some more people are still logging in. So I'm going to give them just another minute and then we will get started.
How many people are logged on so far?
All right, I think we're going to get started. Hi everyone, and thank you for attending Envia Fertility's Patient Education webinar. My name is Vicki, and I'll be your moderator for this informational session. I'm honored to present to you the panelists of our webinar, Dr. Vishwanath Karande, Dr. Elizabeth Puscheck, and Dr. Segal Klipstein. Dr. Karande completed his residency in obstetrics and gynecology at the State University of New York at Buffalo, and he completed a fellowship in the subspecialty of reproductive endocrinology and infertility at the prestigious Jones Institute for Reproductive Medicine at the Eastern Virginia Medical School in Norfolk, Virginia. He will be teaching us what infertility is. Dr. Puscheck trained at the Washington University Medical School in St. Louis and then completed her fellowship at the Medical College of Georgia. She'll be teaching us about uterine evaluation and male factor. Dr. Klipstein trained at the University of Chicago for medical school and then completed her residency and fellowship in reproductive medicine at Harvard University. She'll be teaching us about infertility treatments. All three of these physicians are board certified in the specialty of obstetrics and gynecology and the subspecialty of reproductive endocrinology and infertility. Now that you know a little bit about us, we would like to know a little bit about you. I'm going to put a poll up on the screen, just asking you where you are in your fertility journey so that we can kind of get a feel for who's in our audience. Okay, votes are kind of slowing down. Give it a few more seconds. Okay, I'm going to close the poll now. I would like to share with you the results. I like to see that a lot of them are current. A lot of you are current fertility patients at Envia. We're going to have other polls during the presentation, and we would be grateful if you would share your responses with us. If you have any questions, please type them in the Q&A section, and we'll have time at the end for a question and answer segment. I'm going to proceed. So make sure you put it in the Q&A box, not in the chat box, because we won't see those. Now I'd like to turn this over to Dr. Karande to start his segment on Fertility 101.
It's a pleasure to be here today, and I'm going to be talking about a topic which is very dear to me. In fact, I've devoted my life now to helping infertile couples have babies. And I'm practicing now in a time when, as Dr. Howard Jones, my teacher, would say, the technology has now advanced to a point where if you are persistent enough and make the adjustments required, you will have a baby. So with that introductory remark, let's start with what is infertility. Next. Oh, before that, a little plug for, let's go back on. For Envia Fertility, we have 4 locations in Hoffman Estates, Arlington Heights, Northbrook, and Crystal Lake. Very convenient, and there should be an office close to you. So let's go to the next one. So what is infertility? Next. Infertility is defined as the inability to conceive after 1 year of unprotected intercourse. 1 in 7 couples will have a problem conceiving. 50% of couples will conceive within the first 6 months of trying. 85% will conceive in the first year of trying. Another 10% will conceive in the second year. So in the second year of trying, your chances of conceiving are about 3% a month. So at the 1 year mark, it's reasonable to at least meet with a specialist and have some testing done to make sure there's nothing seriously wrong. Next slide. Is the incidence of infertility increasing? Surprisingly, the answer is no. The overall incidence of infertility has remained relatively unchanged for the past 3 decades. Now, there have been tremendous progress in fertility treatment with the introduction of in vitro fertilization and other assisted reproductive technologies. The other thing that has changed is women are attempting pregnancy now at older ages. And now with the internet and greater media attention, there is more public awareness of infertility. And because of all these factors, infertile couples are more likely to seek medical advice, evaluation, and treatment. Next. There's also, women are pursuing careers and are getting advanced education. There's later marriage and more frequent divorce. There's improvements in contraception and access to family planning services. There's delayed childbearing and decreased family size, and all these have contributed to the decreased birth and fertility rates in the US. Next. So what are the causes of infertility? 35% of the time it will be the female partner, 35% it will be the male, and 20% we will find issues with both partners. And sometimes when we do the tests, the results all come back normal, and that happens in about 10% of cases. And in those patients, we just work towards helping egg and sperm find each other. Of course, as age increases, so does the risk for infertility. Next. So what are the common causes of infertility? One of the very common causes is polycystic ovary syndrome. And in fact, Dr. Puscheck did a webinar on this topic 2 weeks ago, and there's an entire hour of wonderful content which you can access to on our Facebook page. Hypothalamic, meaning in patients who have lost too much weight, or elite athletes, runners, they lose so much body fat that at some point they stop ovulating. Other ovarian causes include aging, and I'm going to be talking a little bit about diminished ovarian reserve. Some women may have premature ovarian failure. The medical term for that currently is primary ovarian insufficiency. Tubal disease is a very common cause of infertility, and the tubes could be blocked or dilated. Two very common causes of these are endometriosis and infections. So if there's a previous history of any tubal surgery or any history of tubal pregnancy or a ruptured appendix, these could all contribute towards tubal disease. And of course, uterine factors, Dr. Klipstein is going, Dr. Puscheck is going to be talking about these in further details, but this include fibroids, polyps, and scar tissue in the uterine cavity. Next. These are two images here, one showing a normal ovary and the other showing a polycystic appearing ovary. What I'd like you to focus on are these little black circles inside the ovaries called antral follicles. These measure 2 to 5 millimeters in diameter. And if you look at these are called antral follicles, and a normal ovary will have 3 or 4 of these. Versus, look at the ovary with polycystic ovary syndrome. There are more than 12 of these antral follicles in the ovary appearing around the periphery of the ovary like a pearl necklace. So it's called the necklace sign. And this is one of the criteria that's used to diagnose polycystic ovary syndrome. In addition to a polycystic appearing ovary, and remember, this is an ovary that not one with cysts, it's just they have a lot of antral follicles, meaning the ovaries are bursting with eggs, which is a good thing. But a PCO appearing ovary along with irregular or absent menses or hyperandrogenism, meaning increased male hormones, which could be reflected by acne or increased hair growth. So if 2 out of these 3 criteria are present, then you can have a diagnosis of polycystic ovary syndrome. And this affects 7 to 8% of the population. And I practically see a PCOS patient every time I'm in the clinic seeing patients. Next. Now, one of the tests which we do in the office is a hysterosalpingogram, where we inject a radio-opaque dye through the cervix and it outlines the inside of the uterus, inside of the tubes. And when you see dye spilling from the tubes, we know they are open. Now in this particular slide, the first image is showing where both tubes are blocked. And these are blocked at the end of the tube, which is near the uterus. Now this could very well be because this patient has previously had a tubal ligation. If the tubes are just blocked because of some material in the tubal lumen, then we can do tubal catheterization to open up these tubes. The central image is showing dilated tubes. The medical term for this is hydrosalpinx. And these can be due to endometriosis or a pelvic infection. And as you can see, these tubes are dilated and filled with a fluid. This particular patient, the tubes are not repairable and she will require in vitro fertilization. It has now been shown that the fluid from the hydrosalpinx trickles into the uterine cavity and it can either wash away or destroy the embryos, lowering the pregnancy rate with in vitro fertilization. So quite often in patients with tubes that look dilated like this, we will do a laparoscopy and remove the tubes or transect the tubes prior to starting an IVF cycle. The third image is showing a tubal pregnancy. If you look at this dilated portion of the tube, that is a pregnancy. And if you have had one tubal pregnancy, then the chances of having a repeat tubal pregnancy is 6 to 16%. If you have had 2 previous tubal pregnancies, there's almost a 50% chance of a repeat tubal pregnancy, and those patients should go directly to in vitro fertilization. Next. Now I'm going to talk a little bit about diminished ovarian reserve. What you're seeing here is an ovarian assessment report, which is a blood that's drawn on the 3rd day of the cycle, where we measure 5 hormones. But the 2 we focus on are FSH, or follicle stimulating hormone, and AMH, or anti-Mullerian hormone. FSH gives an idea about egg quality, versus AMH, or anti-Mullerian hormone, gives you an idea as to how many eggs still remain in your ovary. We like the FSH level to be less than 10. Above 15 is terrible. AMH, we like the level to be more than 2.1. If it's below 1, then that's not good. But in this particular lab, they combine age along with these 5 hormones, and they come with an egg retrieval score where 11 is a good number. And this patient, the egg retrieval score came back at 9. So she does have mild diminished ovarian reserve. Diminished ovarian reserve and its management is a lecture by itself. You could have a conference discussing the different aspects of diminished ovarian reserve. But we have taken care of so many patients with high FSH and low AMH levels and achieved pregnancy that taking care of poor responder patients is one of the thing which has interested me a lot, and we have helped many of these couples achieve pregnancy. Next. Another common cause of infertility is endometriosis. And these are women who can sometimes be asymptomatic, but the common symptoms of endometriosis are painful periods that are getting progressively worse, pain with intercourse, especially in certain positions, ovarian cysts, and infertility. Now in this picture here, you can see a dilated ovary. This is an endometrioma, where the normal ovary on laparoscopy can be seen. See, this is a normal ovary here, but in this, in the lower left quadrant, you can see the large ovary, which has been replaced by this cyst, which is quite often filled with chocolate material, chocolate colored old blood. This is an endometrioma which can chew out the normal ovarian tissue and once again contribute towards diminished ovarian reserve. Endometriosis is a condition where the lining of the uterus has spilled through the tubes into the pelvis, and these implants grow there and they release immune substances which can then lead to scar tissue formation and involve the tubes. And depending upon the severity of the endometriosis, the clinical picture can vary. Patients with mild endometriosis quite often can get pregnant with intrauterine inseminations, but those with endometrioma, especially older patients, we tend to be very aggressive with treatment and go directly to IVF. Next. So with this brief introduction, let me now hand on the baton to Dr. Puscheck, who will be talking mainly on uterine issues and male factor. Liz?
Thank you, Dr. Karande. I appreciate that. You did a wonderful introduction of the aspects of infertility regarding the ovary and the tubes. And I'm going to focus mainly on the uterus and some of the more common things that we find as abnormalities in the uterus, and then also talk about male factor, which accounts for about 35% of all infertility. Next. So the uterus, or the womb, is the place where the embryo is going to be implanting. It's the incubator for the embryo, and it's really important that we have that uterine cavity be normal. It is a potential space, which means that normally the inside layers are approximating each other. And when we want to evaluate the uterine cavity, we're going to put some fluid into the uterine cavity, like you heard about with the hysterosalpingogram, which is the X-ray test, where you can see just the inside of the uterine cavity and whether dye goes out the tubes or not, or what's called an SIS, which is an ultrasound test that can also evaluate the uterine cavity, but instead of using contrast material, we'll use fluid, and sometimes this can be tolerated better. This test, for both of these tests, they're done in the early part of the cycle, right after the period, but before you ovulate. And that's really important because that's when the lining is the thinnest, and we can get the best view of the uterine cavity at that time. Next. So in these two images that are next to each other, we see on the left side a hysterosalpingogram of a normal uterine cavity, which is this triangular shape. And here we see normal tubes, so the dye is going out the tubes. On the right side, I'm just showing you one of the many panels that we look at with ultrasound, showing the long view of the uterus, and that black area on the inside is the cavity. And when we see a normal cavity, it looks just like this. It has, it's all black and it's very smooth. As we're looking at the different problems, you're going to see things coming into the cavity, and that's how we make the diagnosis. Next slide. In addition, when we're using ultrasound, we can actually look at the tissues surrounding the uterine cavity. So we still see on the left side 4 panels, which are the two on the top are the 2D or two-dimensional portions of the ultrasound that's done normally. And then in addition, we can now do 3D ultrasound. So it's we're 3-dimensional people. So instead of having just 2 dimensions, we actually have the 3rd dimension. The 2 panels on the bottom are showing the 3D version of the uterus. So again, now we can see that triangular shape of the uterus like we saw in the X-ray. And on the right side, this is a rendered view. We can actually look at the surfaces of the inside of the uterine cavity. So this particular type of ultrasound, either 2D or 3D ultrasound, we get more information than just looking at whether or not the cavity is normal by what's filling there, but we can look at the tissues surrounding it. And for tissues that are invaginating into the uterine cavity, we can actually make a diagnosis, and a number of these things can be treated in the office. Next slide. So one of the things that we can see is a birth defect of the uterus, and there's different types of birth defects. One of the most common type is what's being shown here, which is a septum. So on the left panel, the one that's vertical, the top one is a 3D ultrasound that's being performed in the latter half of the menstrual cycle, so that the lining of the uterus is its own contrast. That shows up whiter because it's thicker at that time. And the lower half of the panel, I'm showing that same image, but I'm emphasizing that now I'm seeing the surface of the uterus, and you can see it's smooth on the top, and there's this indentation going into the uterine cavity. So it actually looks like a heart shape on the inside, and that's how we'd make a diagnosis of a septum. The right panel, which is horizontal, is a different type of septum that's coming all the way down. It's a complete septum going through the uterus and through the cervix. And again, I can show that there's a smooth top where I showed the yellow line and how it's invaginating into the uterine cavity with how it's coming down into the lining of the uterus. And this is one of the ones that can be treated in the office, and I'll show you an image of that later, but I want to show you a couple other types of birth defects that we can pick up as well. Next slide. So the two panels from the left to the right are the bicornuate uterus, and here we're seeing the indentation of both the outside and the inside. So it's heart-shaped both on the outside and the inside. And then again, like the septum I showed you before, a smooth one on the top with an invagination on the inside. Now I put a line across here because we can do measurements, and those measurements can be helpful in making the diagnosis. But for right now, I think it's just important to show that one's a heart-shaped uterus, that the bicornuate uterus, we often don't have to treat surgically. And next slide. This is a blow-up of the bicornuate uterus. Usually these patients, they may have a miscarriage or two, but over time, you'll get a baby that goes to term. And so we often don't need to treat this one. They get enough blood supply to the both areas of the horns. The next slide. The septum, on the other hand, is more fibrous, and there's not a good blood vessels going to the septum. And on the left picture here, you see the part that says S, that's actually the septum. It looks whiter, and there's an R and an L showing the right and the left horns of the uterus. The uterus is actually formed in utero before you were born by two tubes coming together, and they're basically fused together, and then the inside's supposed to resorb. In this situation, which is one of the most common birth defects, the inside didn't resorb appropriately. So we can surgically correct this in the office by just clipping that septum. Again, the woman is asleep in the office. We are able to do these types of procedures with the anesthesia in our office, and this opens up very nicely, and it can be very rewarding because the uterine cavity goes back to being normal very easily, and there's usually no scarring or anything like that afterwards. Next slide. Oops, next slide, please. Did I lose Vicki?
No, hang on one second. I'm
Okay.
sorry, I'm having a technical issue over here. Sorry.
Not a problem. The more important thing for couples who are trying to get pregnant is not just to make the uterine cavity normal, but the fact that when we remove these septums, that the miscarriage rate goes down and there's a much better pregnancy rate. So on the green here, it says prior to surgery, the miscarriage rate with a septum in place is about 88%, with a term delivery rate about 3%. And then after that surgery, the miscarriage rate has gone down to 14%, which is actually a normal miscarriage rate in a reproductive population. And the term delivery rate goes up to 80%. So it's very rewarding when we find something like this, we can correct it, and you may get pregnant on your own the next cycle. And we just need to wait till the next cycle. It'll heal very quickly. Next. One of the other more very common problems that we find in the uterine cavity is something called a polyp. On the left side, you see the 2D ultrasound where we have the fluid going into the uterine cavity. And then instead of being smooth, on the far left side, you can see there's something sticking into the cavity, almost like a finger. It's not a finger, it's a polyp, and it's just an outgrowth of the lining of the uterus, the endometrium, but it has its own blood supply. So it doesn't go away when a woman has her period, it stays there. And the problem is that this can cause inflammation, and it can reduce the chance to get pregnant, as well as have a higher risk of miscarriage. The right panel, I think, makes that polyp even easier to see in this 3D version. And with the 3D version, I can actually rotate the uterus and look at it from different directions, so I can really see where it's attached, and that can be helpful in the operating room. Next slide. Again, these can be removed very easily in our office procedure room. And when we do remove these polyps, the pregnancy rate with the polyp in place is only about 28%. We can remove that and the pregnancy rate goes up to 63%. So much improved pregnancy rate. Again, right after we remove the polyps, that very next cycle, you can try and get pregnant, and it can be, again, very rewarding. Again, we want that uterine cavity to be normal, and removing this is very, a very good thing to do to help you get pregnant. And these polyps tend to be benign. Over 99% of the time, they're benign, meaning that they're not a cancer or anything. They're just, when we remove them, there's nothing more to worry about. Okay, next slide. Fibroids are also very common, and this is a schematic just telling you where these things are located. So the polyps are only found in the uterine cavity, and they're soft and fluffy. Fibroids are like hard balls of muscle, and that's what they are. They're made out of the muscle of the uterus. We think it's a monoclonal development of one of the muscle cells that have made more and more copies of itself. These fibroids can be found anywhere in the uterus, in the uterine cavity, in the muscle of the uterus, or on the outside surface of the uterus, and we classify them that way. The fibroids can happen anywhere between 20% to 80% of women, depending on your ethnicity and your genetic makeup. The ones that we're most concerned about for fertility purposes are those that are interfering with the uterine cavity, like 0, 1, and 2. Next slide. These are some pictures of fibroids. You can see on the left panel, I've measured one that is just on the outer surface of the uterus and going into the muscle. And then on the right side, there's one that's more in the muscle of the uterus, and there's a little line there. It's kind of shadowing over that line. So we'd want to make sure that line is the uterine cavity. We want to make sure that that is not involved. So women can get single fibroids, or next, multiple fibroids and large fibroids are also possible. So these are just showing a number of different types of fibroids, some that are very large, like 5 centimeters, 6 centimeters, and others that are in multiple different locations of different sizes. Again, the ones that are in the uterine cavity are the ones that have the greatest impact on your ability to get pregnant and stay pregnant. Next slide. So a fibroid in the uterine cavity, again, it can be determined if it's in the uterine cavity by doing that saline infusion sonohystogram, or on the C panel here, we can see a 3D ultrasound showing that it's really in the uterine cavity. The 2D ultrasound may not be as good at telling whether it's a fibroid or a polyp and where it's located. And on the A panel, we're actually showing some of the blood vessels going to that mass in the uterus. So these are different techniques that we can use in ultrasound to help identify whether it's a fibroid and where it's located. Next slide. So again, the fibroid position impacts the fertility outcome. So on the leftmost column of this table, you'll see the different names for where they're located. So submucosal and submucosal intramural are the ones that are interfering with the uterine cavity. The one that's intramural is mostly in the muscle of the uterus. And then intramural and submucosal is, again, another combo that's more in the intramural, but still impacting the cavity. When we look in the control groups with these types of fibroids with no surgery, we see those pregnancy rates there. And they're much improved once the surgery has been performed. So we can do, these are done with a hysteroscopic procedure, and the pregnancy rate went from 27 to 43%. The green box is showing that they're statistically significant, and which means that much better pregnancy rates. The bottom one also had a significant increase, and the one that's just intramural, we don't see any difference really between the control and the pregnancy rate after surgery. So 41 to 56 isn't a big change. Okay, next slide. The intrauterine adhesion, so scar tissue in the uterine cavity, is also not uncommon. I have two pictures here that I'm showing you. One has an arrow on the left side showing a filmy adhesion. This woman really didn't have any symptoms. She was just presenting with infertility and had this evaluation done, and yet this scar tissue can be interfering with her ability to conceive. And the one on the right actually has a thicker scar tissue. You can see the two black circles there. Those are the cavity, and then the thicker piece in between is the scar tissue. And she was complaining of lighter periods. Women who have scar tissue in the uterine cavity often will present with lighter periods or no periods, and this is indicating that there's a problem with the uterine cavity. I like to think of scar tissue as if you think of buttered bread and those edges coming together where the butters come together, that's like a scar tissue between the muscle of the uterus. And we want to open that up and we want to heal that so it's more like the unbuttered side and it doesn't stick. And so we do different techniques to actually remove the scar tissue and decrease the chance for it to return. Next slide. Again, when we make the uterine cavity normal, those pregnancy rates really increase. So here we have high pregnancy rates noted by a number of different studies. We can actually stage the type of scar tissue, and the milder stages have a better outcome than the ones that are more severe. But if we can get that uterine cavity back to normal, the pregnancy rate and the live birth rate goes up significantly. So these are great outcomes for patients who were having problems with getting pregnant, and they had very light periods or no periods. So next slide. In summary, what I've talked to you about with the uterine cavity assessment is that we want to make that uterine cavity as normal as possible prior to doing fertility treatment so that you have the best chance to get pregnant the first time around. So we can fix those septums and polyps and adhesions all in the office. Fibroids will often take to the operating room in a hospital to remove. But all of these procedures, when we get the uterine cavity back to normal, improve pregnancy rates significantly. The next thing I want to talk about, next slide, is the male factor. Now, the male partner accounts for about 35% of infertility problems. And so it's very important when we're taking the history of a couple trying to get pregnant that we get the history of not just the female, but also of the male partner. We're going to be thinking about things like, was normal development happening? Did puberty happen normally and at the right time and without using any medications? Were there any incidents of toxin exposures or trauma or prior surgeries in the genital area? And then the main test that we use for assessing the male, at least initially for the screening for fertility, is the semen analysis. On the bottom slide, I have an actual picture of sperm that we've stained so we can look at the morphology or the shapes of the sperm. And if you look on the right side of this slide, the sperm can be in many different shapes. The topmost on the left is the normal, but we have some that have bigger heads or smaller heads or double tails, and we're looking to have a certain number of these be normal. And the way we do that is by looking at a semen analysis. So next slide. That semen analysis, we do about 20 different criteria that we look at. The key ones to be thinking about for getting pregnant are the ones I have listed here on the right. We look at the volume of the ejaculate and like to see that about 1.5 or more. If that's low, that might be due to anxiety. So sometimes we'll do a second or a third semen analysis if any of these tests are abnormal to see what's most common, because men's sperm counts can vary dramatically from one day to the next. However, if we're seeing a persistent problem, then we need to deal with it. Now the concentration is really the count of the sperm per volume. So we want to see 15 million or more sperm per ml, and that would be normal. The motility, we want to see 40% or more, and motility is just the mover. So the sperm moving, we like to see them moving forward, but even if they're just moving, wiggling their head or jiggling, we know at least the sperm are alive, and that's also helpful. But the motility is really important to help fertilize the egg. And then the morphology, like I just mentioned, only need 4% of those to be normal, believe it or not. It's not a very high number, but that's all you need for the sperm to be functional and helpful in getting pregnant. Next slide. When we do find that there's an abnormal semen analysis, as I mentioned, we'll want to do a second or a third one. And if we're seeing persistently abnormal levels, then we're going to do further evaluation. If you focus mainly on the counts for right now, if we're seeing abnormally low counts or no sperm at all, then we're going to want to do an assessment, both of a hormonal assessment and a genetic assessment. There are hormonal evaluations that are very treatable. Some men are big into doing bodybuilding, and if someone is using testosterone or other steroids, this might actually shut down their sperm production, and we can help treat them by removing that. Other things that we might want to treat might be a prolactin problem or a thyroid problem, or sometimes it just gives them an assessment that we're going to need to help boost their treatment with a Clomid or a Letrozole. That's something that we've often used for women, we can often use for men too. Other times we see genetic disorders, particularly with the very low counts or zero counts, and those genetic disorders can be passed on to the baby, so it's really important to get those tests done prior to treatment. And some of those genetic disorders will let us know that we're not likely to find sperm, and others are going to say, yes, we're going to be likely to find sperm, but we might have to use a surgical method to actually identify the sperm. And some men have had vasectomies before because they thought they were done with their families, and now have changed their mind. They have a new partner, and they want to have another child, but they may not want to go through a surgery to reverse the vasectomy. Well, there's a way we can get sperm without using a reversal approach. And those techniques are in the next slide. There are surgical procedures, and a number of these surgical procedures can be done in the office as well. So if someone has had a vasectomy, we'll use one of the two panels on the far right, which is just basically an aspiration of the epididymis to get sperm that can be used. In situations where there has been more of a genetic issue, like a Y chromosome microdeletion just happens to be one of them that has a particular mutation in the C region, then we're more likely to find sperm in the testicle area, may need to do more of a biopsy to get those sperm out. When we're talking about using these kinds of surgical approaches for treating male fertility, we're not going to get a lot of sperm. So in these situations, we're going to need to use the higher tech approaches to help the fertilization of an egg to happen. So we'll actually do something like in vitro fertilization with what's called ICSI, where we put one sperm into an egg, and this will help with fertilization. And we've had a number of patients get pregnant by this route. Of course, if a man can ejaculate and produce sperm that way, that's the preferred route, but we do have an armamentarium of approaches to help men get pregnant too. So I'm going to conclude my portion of the talk here, and I think this is a good segue because these types of procedures can be very helpful at helping the treatment of infertility. And Dr. Klipstein is going to go over the different types of low technology treatment all the way through the high technology treatment like in vitro fertilization. So thank you very much. It was delightful talking with you today, and I look forward to your questions at the end of our presentation.
Thank you. Very nice to see everyone today. So I have about 10 or 12 minutes to tell you everything I know about the treatment of infertility. So I will do my best. Next slide. There are lots of different treatment options, starting from the most basic or maybe the easiest ones to the most complex and most successful. These vary from the oral agents, so various pills that we use. The most common are Clomid and Femara. These induce ovulation or induce more than one follicle to develop. When we use the oral agents, we often add intrauterine inseminations or IUI, where we take the sperm and we concentrate it and we put it right in the uterus. We can also use injectable medicines. And then the most successful, most complex thing we do is in vitro fertilization. And when we do that, we can also add some other things. Dr. Puscheck had mentioned intracytoplasmic sperm injection for men with low sperm counts, also pre-implantation genetic testing, which I'll talk about briefly. Next slide, please. So there are two ways to use the oral pills. One is for ovulation induction. And so this is using pills for women who don't typically have periods or don't have regular periods. And the goal is to normalize the period so that women ovulate. And in these women who typically don't ovulate, the goal is to mature just one follicle at a time and make her kind of similar to everybody else, and release the one egg. In women who already have regular cycles but still do not get pregnant, the approach is different. The theory is that if you're already making one egg and not conceiving, perhaps ovulating 2 or 3 eggs might be a better approach. And so here, the goal is to mature more eggs, and this is most commonly used in unexplained infertility. Next. So Clomid is the very first fertility drug that was developed, and it was synthesized in the 1950s, and the first pregnancy with it occurred in the 1960s, so really quite a long history. It was approved in the 1960s by the FDA, but it was initially thought to be a contraceptive agent. It was thought to have an anti-fertility effect, but then women who took it ovulated, and lo and behold, here we are, we have our most long-lasting, widely used fertility treatment. Next. How is this given? It's fairly easy to take. It comes in a 50 milligram pill, and the dose is either 50 or 100 or sometimes 150 milligrams a day for 5 days. And you start it on either day 3 or day 5 of the menstrual cycle. And then you have to check for ovulation. How do you do that? You can use an ovulation kit. You can do it the fancy way that we often do in the office with blood tests and ultrasounds, but you want to check for ovulation for 2 reasons. 1, to make sure that an ovulation is occurring, and 2, so that intercourse can be timed to the ovulation for maximum benefit. Next. There are some side effects, and don't let this slide scare you too much, but women experience usually mild side effects. Sometimes hot flashes, nausea, headaches, breast tenderness. The one most troublesome side effect is mood swings, and these are fairly common. And then very rarely women can have blurred vision or double vision. And the other side effect that we talk about with Clomid is an increased risk of twins of about 8%. Next slide. So what are the success rates with Clomid? Well, it really depends on why you're using it and your age and a number of factors. But generally, women who don't regularly ovulate and take Clomid, in those women, 75% will ovulate. And of those 75%, every cycle that a woman ovulates, 15% of the time she'll become pregnant. And actually, this is the same success rate as couples in the bedroom. That's about the best you can hope for, is 15% a month. So it really just normalizes their cycles and kind of makes them equal to everybody else. In women who have unexplained infertility but have regular cycles, the chance is a little bit lower because you're really just, instead of producing 1 egg, you may be producing 2 or 3, and so you're increasing the chance a little bit. 8% per cycle is the general expected success rate. And in women over 40, Clomid is not a great option because the chance of success is usually less than 4% per Clomid cycle. Next. The newer medication that's also in pill form is called Femara or Letrozole. Next slide. And this also is given very similar to Clomid every day for 5 days. But while Clomid works by making the brain believe that it's not seeing estrogen, Letrozole blocks the estrogen peripherally in the rest of the body. So because it doesn't work on the brain, it doesn't have the same sort of effects on the mood or on sometimes on the vision changes. And it was initially developed for treatment of breast cancer, and women after breast cancer diagnosis and treatment often take this for 5 years or longer, and sometimes they take it just for if they're at high risk for developing breast cancer, for prevention. But it's been found to be very successful also for inducing ovulation, and it has fewer side effects, next, but not no side effects. Some women complain of hot flashes and vaginal dryness. It is thought to have a lower risk of twins. So like I said, with Clomid, the risk of twins is about 8%. Here it's maybe 5%, 6%. It works really well in women with polycystic ovarian syndrome. And you can hear more about this in our previous webinar that Dr. Puscheck did, all on PCOS. It's often better actually than Clomid in inducing ovulation for women with PCOS, particularly women who are higher weight points. And next. Oftentimes with the oral medications, we add intrauterine insemination. The benefit of this, there's several benefits. One is that it increases the amount of sperm that gets to the uterus. So after intercourse, typically, even though a man might have 100 or 200 million sperm in his ejaculate, only 10 or 20 or 30 of those sperm, maybe 100 might make it to the uterus. But if we take that sperm and we concentrate it and we inject it directly into the uterus, you can get millions of sperm there. So more sperm, eggs that are released, and better chance of pregnancy. So this is good for mild male factor infertility. If the sperm count is very low, then you need in vitro fertilization. But if it's mildly decreased or mildly affected, then this may be a very good option. And especially with women who undergo Clomid, the success rates that we quoted are really success rates when we use intrauterine insemination, because the cervical mucus can become what we call hostile. It can become thick, and it may be harder for the sperm to navigate that cervical mucus to get into the uterus and the tubes and meet with the egg. So we often use intrauterine inseminations when we perform Clomid cycles. Next. What about injectable medications? So if the fertility pills don't work, or maybe they're not thought to be strong enough, for example, in women over 40, you can use injections, and these are more expensive related to the oral medications. They're injected subcutaneously, so under the skin like insulin. Success rate's a little bit higher in some cases than Clomid, 10 to 15% per cycle, or than Letrozole, but there is a high risk of multiple gestation, especially in women under 40. Quarter of the pregnancies will be twin, and 9% may be triplets or more. And because of these reasons, and because IVF is so successful, these injectable medications are used much less frequently than in the past. Now, when we do IVF, we do use these injectable medications to stimulate the ovaries, but we don't just have the couple have intercourse or put sperm in the uterus. We actually take the eggs out and then put the fertilized eggs back one at a time, so the risk of twins or triplets is quite low. Next. So let's talk about in vitro fertilization. Next slide. This is the most successful thing we do, and we do many hundreds of cycles of this every year. Like I showed you, those fertility medications are injected here in panel number 1, right under the skin. I barely feel it, but it is difficult sometimes to get over the hump of injecting yourself with medications. And then in the second panel, number 2, you can see an ovary that typically ovulates only one egg, but here you can see multiple eggs that are ready to, or multiple follicles that will have eggs in them that are ready to ovulate. And right before the ovary releases its eggs naturally, timed to ovulation, we perform an egg retrieval. So the woman comes to our office, gets a little bit of IV anesthesia, goes into a twilight sleep so she doesn't feel anything. An ultrasound is placed in the vagina, and a needle is guided through that ultrasound into the ovaries. You can see these black circles in panel 2. These are fluid-filled sacs. The eggs come out of them. They're just floating in that fluid, and the embryologists sit under the microscope and they wait for the fluid. The actual fluid comes in a test tube. That's the only test tube part in the process, as you can see here in panel 3, and then take the eggs out so that they can be mixed with sperm. Next slide. The eggs look like here in number 4. Fertilization I'll talk about a little bit in the next few slides, but what you can see is one egg with lots of sperm around it. And then in panel 6, this is the most beautiful thing, I think, that happens, and this is when the nucleus of the egg and the nucleus of the sperm meet, and you can see in the middle there are 2 sort of concentric circles joining, and this is the DNA basically fusing from 2 individuals to make 1. And this is when the embryo starts to form. It divides into 2, then to 4, then to 8 cells, and so on, doubles every number of hours, and then forms an embryo, and that embryo is then later transferred into the uterus. Next step, next slide. When we perform IVF, sometimes we do that for male factor infertility. So typically, kind of the more traditional IVF is this panel up here on top, where you put 1 egg, and then around each egg, you just put a drop of thousands of sperm and let the best man win and find its way into the egg. But if the sperm counts are very low, or the sperm isn't moving, or there's a low percentage of normal sperm, you can actually inject 1 sperm directly into the egg and create fertilization in that way. And this is what you see on the right side of this bottom panel. The little pipette, the little tube is carrying one sperm and putting it right into the egg. And it can overcome issues such as fertilization failure. Next slide, please. If you look, this is a slide looking at national data from across the country. We all report our success rates to this database. And this is the success rates for the last year, which has been reported. And what you can see is this is the success rates in terms of live births per new patient. And if a woman is young, under 35, there's about a 70% chance that she'll leave with a baby from her treatment with IVF. As you can see, age is everything, and as a woman gets into her 40s, the success rate is lower and may require more cycles in order to achieve a pregnancy. Next slide. Now, when we have these embryos, we can do several things with them. One is we can test them for what we call aneuploidy or chromosomal abnormalities. So we know, for example, that if there's an extra chromosome 21, that results in Down syndrome, but there are many other missing or extra chromosome numbers in the embryo that can result in either miscarriage or no implantation at all. And so if we do genetic testing of the embryo, we can decrease the miscarriage risk. We can detect disease prior to implanting an embryo in the uterus. So if the couple is a carrier of like cystic fibrosis or Tay-Sachs or thalassemias or sickle cell, we can test the embryo for that and prevent the birth of a baby with one of these diseases. And it also increases the chance that an embryo will implant. So for example, in a woman who is under 35, the chance of any given one embryo implanting is about 40%. That goes up to closer to 70% if we can identify an embryo that's chromosomally normal and put that one in the uterus. Next. So in conclusion, we have lots of different treatment options. We could spend hours talking about each one. It's really important, though, to pick the protocol that's best for you. At INVIA, we don't believe that everybody sort of fits one pattern and that there's an algorithm. Every patient is looked at individually, both in terms of their medical determinants as well as their goals and what types of treatments they're interested in doing and what feels comfortable for them. And so no two individuals are the same, and we really fine-tune a treatment for each individual and couple that comes to see us. And this leads to excellent success rates, and we're very proud of those. So let me open it up, and we'll all show ourselves on the video to question and answer session. So thanks to those of you that have sent questions, and I think Vicky, you will moderate that and go from there.
Okay, I'm unmuted finally. So I'm just going to take turns with you guys asking you questions. I'm going to start with Dr. Klipstein. Is it atypical to prescribe Clomid or Femara alone or not alongside fertility treatments?
Yeah, so Clomid and Femara are considered fertility treatments, and you can take them on your own without sort of monitoring by a fertility specialist, but it's not ideal because you won't be able to identify if you're ovulating, and you won't know how well you're responding to it. But yes, as an initial treatment, you can certainly do that, and oftentimes your OBGYN will prescribe these for several cycles, and if that's not successful, he or she will refer you to a fertility specialist.
Okay, Dr. Puscheck, can you explain the difference between an HSG and an HSN?
Certainly. So an HSG is a hysterosalpingogram. That's the X-ray test that you saw earlier. We put some contrast material into the uterine cavity and see the tubes open. An HSN is a hysterosonogram. So it's another, there's a variety of different names for the ultrasound test. I tend to like to use the word SIS better because HSG and HSN sound very close. And if you use SIS, which is saline infusion sonohysterogram, then it's, I think, a little bit easier to realize it's the ultrasound one. So it's the ultrasound. The HSN is the ultrasound version of HSG, but it's using the saline and the ultrasound to look at the uterine cavity and the tubes.
Okay, Dr. Karande, for
Yes.
couples who have been diagnosed as unknown fertility, would you recommend they get a second opinion?
No, not if you are otherwise happy with your doctor. When I started practicing many years ago, we used to do a lot of tests because those days we were not very good at actually getting people pregnant. So we used to do tests like a postcoital test and endometrial biopsy and immune tests, and it used to go on and on and on because we used to try and find why the couple is not conceiving. But now we are so good at getting egg and sperm together that after doing just a preliminary test like blood hormones, checking the uterus and tubes, and doing a semen analysis, the next step usually, if the tubes are open and there's a good amount of sperm, is to proceed with ovulation induction using Clomiphene, Citrate, and timed insemination. So the next step does not really change whether there is a definite cause of your infertility or it's unexplained.
Okay, Dr. Klipstein, is there a specific age where you would start recommending PGT more for a female?
Yeah, that's a very good question. So the chance of you having chromosomally abnormal embryos grows as you get older. So for example, in a 20-something-year-old woman, maybe 20% of the embryos will be chromosomally aberrant, but in a woman who's, let's say, in her mid-40s, it could be half or 3/4 of the embryos, if not more. By age 43, 45, it could be 80% of the embryos. So the older you are, the more helpful it is. So for everybody, it'll be helpful because transferring an embryo that's chromosomally normal increases your chance of success. But for the youngest women, they already have such a high chance of success that you're not really increasing that chance so much. I would say the sort of tipping point is somewhere around age 35, where as you get further into your 30s, the benefit is higher for using the genetic testing of the embryos.
Okay, Dr. Puscheck,
Yes.
what can a male do to increase his sperm count at home?
So what I'm understanding the question to mean is that how can you improve your fertility if you're a male without using fertility drugs? Well, certainly we would recommend those things that would optimize your health. So eating healthy, having routine, regular sleep, moderate exercise, not excessive. And then vitamins. So most of us are not eating healthy enough to get all the vitamins that we need. And we do know that there's certain antioxidants that can be helpful to help reduce what are called reactive oxygen species and other things that could be interfering with their fertility. So these could be things like vitamin C, lycopene, and a number of other things. We like to use CoQ10 as a supplement. And then vitamin D is another thing that has been associated with infertility. And so we often will give vitamin D too. So those are things that you can do at home easily using some vitamins and optimizing your health, keeping away from hot tubs or anything that's going to increase the temperature of the testicle. The testicle is outside of the body and a degree or two less than the rest of the body temperature. So those things that are going to increase that temperature will also have an impact on the sperm. So keeping out of hot tubs or saunas is a good thing too. And there are some other things that we could go into at another time when we have more time, but I think that's a nice overview for giving you some ideas.
Dr. Karande, we have a question. What is egg quality?
Egg quality is the ability of an egg to achieve a pregnancy. Egg quantity is how many eggs still remain in the ovaries. So as you know, a woman is born with all the eggs she's ever going to have. Around age 28, a woman's fertility starts decreasing. After age 35, it decreases further. After age 40, it goes into free fall. So keeping this in mind, with older patients, we will tend to be more aggressive with our treatment recommendation.
Okay, Dr. Klipstein, this one just came in. When should a woman start trying to get pregnant or thinking about freezing her eggs?
As soon as she's ready. Certainly, this is, I don't know if this is really a medical or a social question, because certainly you don't want to get pregnant before you're ready. But I do think that obviously it gets harder as you get older. And if you're in a relationship or in a position to have a baby alone and you're ready, I think you should do it as soon as you are possibly ready. Having said that, the question is, at what point, if let's say you want a baby but you're not in a place where you're ready to have one, should you freeze eggs? And the older you are, the less eggs you'll get. But the younger you are when you freeze your eggs, the less likely you are to use them, just because you have a lot of time to get pregnant and you may down the road, not have any issues with your fertility. So I would say starting around age 30 or 32, you should start thinking about freezing eggs if you're not in a relationship. I call a relationship with reproductive potential. And that way, if you need them, you have them. And if you don't need them, that's okay. No harm, no foul. But, I think a lot of women are very appreciative down the road, having frozen their eggs and knowing that they have a much higher chance of pregnancy with those frozen eggs than they would with their eggs today. And it's a great option. So I would say not so much in your 20s, unless you have a reason to think that you're losing your fertility younger. Maybe your mom went through menopause early, or maybe you had some sort of chemotherapy or treatment, or you're about to, that can affect your fertility. But certainly in your 30s, you should think about freezing eggs. And as a fertility doctor, I guess I would say really as soon as you're ready, have a baby.
Okay. Dr. Puscheck,
Yes.
If I'm older and I've been trying for a few years, can I jump right into IVF, or do I have to do IUI's Clomid Femara first?
Well, I think this is a question that is not just medical, but it's also insurance related. It's unfortunate that sometimes we defer to the insurance. We're very lucky in Illinois that insurance does cover a lot of fertility, but some of the insurances do require inseminations prior to going to IVF. In an older woman where I'm worried about their chances of getting pregnant, as you heard earlier, Dr. Karande mentioned that we tend to be more aggressive and we want to have that success happen sooner. It's very reasonable from a medical perspective that if we have done an initial workup and we're mainly dealing with age, that we might want to go right to IVF. If it's a woman who is 40 and wants to move forward with even with PGT, or she's going to have a much better pregnancy rate than she would be if she tried using Clomid, Letrozole, or inseminations ahead of time. But insurances may not cover it if we go directly to IVF. Now, sometimes we can write letters to the insurance company and get coverage if we can demonstrate that there's a good reason to move to IVF sooner. So yes, I think there's a role for doing that. I certainly have had couples who wanted to do that and have been successful doing that. I've also had couples who've wanted to try on their own, but as women get older, I get much more worried about that decreasing fertility rate and higher miscarriage rate, that I agree with being more aggressive.
Okay, Dr. Karande, what are the available remedies for thin uterine lining to enable implantation or conception in a successful pregnancy?
Okay. We generally like the uterine lining to be at least 7 millimeters, sometimes more than 8 millimeters. At the same time, I've had pregnancies in patients where the lining is 5 millimeters. So the main thing you have to make sure is that the uterine cavity is otherwise normal. If there's scar tissue or something else going on to the uterine cavity that has to be removed, the cavity has to be optimized before you pursue treatment. But despite that, if the lining is thin, then we will quite often, and this is usually in a frozen embryo transfer cycle where we are worried about the uterine lining, where in addition to oral estrogen, we start giving vaginal estrogen. And the same tablets which are given orally can be inserted into the vagina. And actually the estrogen gets directly absorbed into the uterus, and that helps promote the lining.
Okay, we're a little bit over time. I'm going to do one more question per doctor, and then we'll let everybody get on with their afternoon. Dr. Klipstein, does your clinic have available donated embryos?
That's a great question. We do. We have a number of couples that go through in vitro fertilization and have more embryos than they need. Of course, you don't know that when you're starting, but these couples have completed their family plan, and they don't want to discard these embryos, and they don't want to store them forever, and they're don't want to use them for themselves, and so they donate them anonymously to our clinic, and then they're available to individuals or couples who might be in need of those. It's a good option for people who need donor egg or donor sperm, or particularly if you need both. Yes, so we would love to have people come our way and utilize these embryos, and we definitely have them available. It's something we're really proud of being able to offer.
Okay, Dr. Puscheck, we've had a couple different questions about this, so I'm gonna try to put them together for you. It has to do with spotting during cycles. If you normally spot before your period starts, or you spot at different times throughout the month, what day would you consider day one to be able to track your ovulation?
Very good question. So spotting is typically not normal, and so we'll usually want to have an evaluation for why someone's spotting. And certainly polyps could be one of those causes, and again, that can be removed. Sometimes people with endometriosis will have some spotting. But if we're trying to figure out what's the first day, I usually will go with a first day of real flow. So if you're having spotting at different times and you want to move forward with just the initial evaluation, then I would go with the day of first real flow, heavy flow. That would be day number 1. So when we're trying to go to day number 2 or 3 to get the ovarian reserve test, that's the day we'd count as day number 1. And if we're going to go day 6 to 12 to do that HSG or the saline infusion sonohystogram, that would be the day that we'd utilize.
All right, Dr. Karande, let's wrap it up with, I've been told I need to use an egg donor to conceive. Can I use a close personal friend or family member who has volunteered to help me?
Yes, you can. That was a short answer, but when that happens, we would do a workup on the non-donor exactly like we would for an anonymous donor. It would basically be checking her ovarian reserve to make sure that she will produce a good number of eggs, increasing the chances of cycle success. When we use a non-donor, quite often we will recommend that they see a lawyer and have a very clear contractual agreement as to what happens after the pregnancy is achieved. This is usually not a problem with sisters, but when it comes to non-family, non-donors, it's probably a good idea to have a legal contract.
Okay, you know I had to put in a donor question. So thank you all so much for attending this webinar and for sharing your responses with us. Thank you also to Drs. Karande, Klipstein, and Puscheck for sharing this information with us. Please check our website for dates of future webinars. If you have a question we didn't get to, or if you think of something you want us to answer for you, please send it to the email info, I-N-F-O, @inviafertility.com. We're going to close with just another poll. And that is, let's see, here we go. Did you learn anything more that you didn't know before watching this webinar with us? So I can't tell if everyone's being nice, but it's an astounding
We'll
yes,
take it.
yes.
I'm glad.
We've done our job.
Excellent.
So on this page is all of our contact info, our website, phone number, Instagram, Facebook, everything. If you need to reach us, please feel free to do so and keep an eye out for our next webinar. Thank you.
Thank you.
Thank you.
Thank you.